Well, good morning, everyone. So it's a pleasure being here with you today. I'm Dr. Said Daneshmand, and with my partner, Dr. Said Daneshmand, we're here from the San Diego Fertility Center. Just a little bit background on me. I've been in practice for about 19 years. I did all my training at UCLA Medical Center. And really for the past 12 years or so, more of my practice has been devoted to helping intended parents become parents with the help of surrogates and for many egg donors as well. So as you know, the process of in vitro fertilization is the way in which we proceed with the process of surrogacy in terms of becoming parents. So what I wanted to do today is talk to you a little bit about in vitro fertilization, how we retrieve eggs, how we maximize the quality of the eggs that we retrieve, how do we maximize the quality of the endometrium or the lining of the uterus to ensure implantation, and of course the birth of healthy babies. So let's get started. I think it's in front of you. Oh, there it is. Okay. So we're going to talk about myth versus science. These are my partners, Dr. Chuan, Dr. Park, Dr. Friedman, Dr. Kettle, and myself. And we're at San Diego Fertility Center. We were established in 1989. More than 50% of our practice is devoted to helping intended parents outside of the United States achieve their goal of parenthood. And San Diego is not a bad place to sort of find yourself at for fertility treatment. It's a beautiful coastal city. We have a very vibrant downtown. And it's not London. We don't have the same culture as you do, but still, it's a lovely place, and we really are eager to welcome you there and take care of you. This is our Del Mar office. We have 3 offices in San Diego. We have an incredible team, state-of-the-art technologies. We use next-generation sequencing for our pre-implantation genetic chromosome screening. This is some of our lab. We now actually have expanded our embryologists to 10, some of the finest embryologists in the world, and really we owe it to them. Some of the incredible pregnancy rates that we've had, we owe to the great work of our embryologists. So in vitro fertilization, IVF with surrogacy, we have a terrific egg donor program. The one difference between our egg donor program and many others is that all of our egg donors are pre-screened. So we've already done psychological testing, genetic screening, egg quality screening. For many of you, when we actually retrieve the eggs, we're dividing the eggs between 2 partners. So we want to make sure that the egg quality is tested and the egg count is tested before patients go through. Whereas sometimes with agencies, you find donors, but we haven't done the screening on them in terms of the egg count. So this is a great option, because when you look at our egg donor database, you'll see a great deal of information on the genetic mutations, for example, that they may carry, their family history, their egg quality screening, whether they've had a cycle before, and if they've had a cycle before, what kind of results have we had? How many eggs did we retrieve? How many blastocysts? Did they undergo PGS testing? So there's a great deal, a wealth of information there for you, and what we do is during our consultation, we talk to you about how to select an egg donor. And of course, there are many things that you're going to select yourself in terms of physical characteristics, education, family background, ethnicity. But from a medical standpoint, especially egg quality, we will really guide you in terms of selecting the best egg donor that's going to maximize your chance of healthy pregnancy. We're going to talk a little bit about the basics of IVF treatment. We're going to talk about genetic screening and when genetic screening is indicated. We're going to talk a little bit about embryo transfer and what are some of the techniques we use to maximize the rate of implantation in pregnancy, and then we'll talk about egg quality as well in IVF. So as you know, in the field of in vitro fertilization, the goal is to stimulate the ovaries to mature and develop multiple eggs. And what we do is we use the same hormones that the brain produces every month to mature and develop eggs, FSH and LH, to stimulate the ovaries to mature and develop multiple eggs. These eggs are developing in follicles or cysts. You'll see that under egg retrieval. What we do is during 10 to 12 days of IVF stimulation, we monitor the follicles, monitor the eggs and the hormone levels. And then what we do is at a specific time, when we feel that it's the right time when the eggs have matured, we retrieve the eggs. And the retrieval is done under anesthesia with a needle that goes into the vaginal canal. What happens then is that once the eggs are retrieved, they're analyzed for maturity, And then what we do is we select out the best quality sperm and inject the best quality sperm inside the eggs. So in the old days, there were some impediments, for example, in terms of fertilization when sperm quality was not good. Some men, for example, have abnormal sperm morphology or motilities. Morphology is really important, which is really the shape of the sperm because it determines the rate of fertilization. So with the advent of ICSI, which is intracytoplasmic sperm injection, we're able to actually select out the best quality sperm and inject the best quality sperm inside the eggs to maximize the chance of healthy and good quality blastocysts. Our lab keeps you updated on the IVF and embryo development every other day. So once your eggs are retrieved or your donor's eggs are retrieved, we keep you updated in terms of how many have fertilized. We typically expect about 80% of the eggs to fertilize. And then what happens is over the course of 5 to 6 days, the embryos will start dividing into 2 cells, into 4, into 8. And then after 5 days, they get to a stage called a blastocyst stage. And then the embryo has to hatch out of its shell in order to attach to the lining of the uterus and develop into a pregnancy. And it's an incredible process that we witness under the microscope. These are excellent quality blastocysts. So when we look at blastocysts, there are 2 areas that we look at. One area is the inner cell mass, which is those group of cells you see at 6 o'clock. Those give rise to fetus. So we assess the quality of the inner cell mass, how cohesive the cells are, the cell structure. And then we also look at the trophectoderm, which are all the other cells that give rise to the placenta and the gestational sac. So we have 2 grades when we look at embryos under the microscope, and we use objective criteria to grade the embryos. If the higher the grade of the embryo, the higher the quality and the higher the chance of pregnancy and implantation. So if we transfer just one embryo that looks like this, which is a grade good, that we expect the chance of implantation and pregnancy and delivery to be about 91%, which was our rate in 2017. So embryos can be graded on their appearance, but there are many features of an embryo that we can't assess just under the microscope. And really, the chromosomes are the next part of the information that we assess. So as you know, there's about 25,000 genes on all 46 chromosomes. An embryo is comprised of 46 chromosomes, 23 from the sperm, 23 from the egg. And what we do is in the process of something called PGS or pre-implantation genetic screening, when the embryo is at the blastocyst stage, we take a few cells from the outer shell of the embryo. Those are the cells that actually give rise to the placenta and the gestational sac. And we take about 4 or 5 cells and then we do a chromosome analysis, meaning that we're looking to see if all the chromosomes from 1 to 23 are paired up. When we talk about a good quality egg versus a poor quality egg, we're really assessing the ability of the egg to align the chromosomes properly in pairs. So as eggs get older, they make more mistakes. The machinery of the eggs get older, and so they make more mistakes, and so you see a higher incidence of chromosomal abnormalities such as Down syndrome. So I don't know if this will play or not. We do have let me see if, can you play this or? There we go. So this is the actual process by which we biopsy. We've created a little hole in the shell of the embryo, and we bring this sort of pipette close by, and then as you can see, we'll basically are taking out about 4 to 5 cells into that little tube, and there you go. Those 4 or 5 cells are sent for chromosome analysis. And then what we do is we kind of get a grid like this, and we're using now what we call next generation sequencing, which means we actually sequence the chromosomes and we get a graph like that. So a normal graph would be a straight line, and any deviation up or down that you see are abnormalities in the pairing of chromosomes. So this is how we sort of assess the 23 chromosomes to see what the abnormalities are. Who can benefit from chromosome analysis? Patients, for example, who have a family history of genetic diseases. If you tell us that you have a family history of thalassemia and you're using a donor who has the same potential genetic mutation, then what we can do is we can take the cells and we can analyze them for the presence of thalassemia or any genetic disease that has been identified. Also, for men who have significantly abnormal sperm, we recommend PGS or next generation sequencing, and then sometimes we do it for sex selection. There are some limitations to genetic screening. There's something called mosaicism, which means sometimes the embryos, trophectoderm, those cells on the outer edge, the chromosomes may be a little different than the ones that are of the inner cell mass. That's called mosaicism. There's some tests that are not available. In other words, there are some diseases like autism or Asperger's or many other diseases we think that have a genetic basis, but we can't test the embryo for those. Why? Because the genes or the mutations have not been identified. And also, there is a small chance that when we do the chromosome analysis and we biopsy the embryo, in about perhaps 10% or less of embryos, that there may be some damage to the embryo and the embryo may stop developing. That's not going to cause an abnormal pregnancy to form, but the embryo may stop developing. Now, it may stop developing and we may identify that under the microscope before transfer, or sometimes the transfer is made and the embryo stops developing within the uterus. So, based on research scientific studies, there doesn't seem to be a significant benefit in PGS or next generation sequencing when you're using a young egg donor, less than 35 years of age, when there's good quality sperm, and again in typical egg donor cycles. How do we know this? Well, there was a great study looking at 9 years of data, of IVF data, and that was from 2005 to 2013. What they did was they looked at all the cases with PGS where egg donors were used, and typical egg donors are between 21 and 29 years of age. And what they found in that particular study was that PGS, or pre-implantation genetic chromosome screening, was not really helpful in significantly increasing pregnancy rates or decreasing miscarriage rates. Now, another area that's important is once we transfer the embryo back in, what can we do to maximize the chance that that embryo is going to attach to the wall of the uterus and develop into a pregnancy? So there's something called embryo glue, and there's been some studies on that. If you look at some of the substances in the uterus that are involved in the ability of the embryo to attach, one of those substances is called hyaluronan. And what we do is we supplement the culture. In other words, when the embryos are growing in the lab, right before we transfer the embryo back in, HA is used as a supplement to improve the rate of attachment of the embryo to the lining of the uterus. So it's called embryo glue. It's a human endometrial transfer medium, which means we add it to the culture medium of the embryos. And in low concentrations along with albumin, it's been shown to improve implantation. And this is a protocol that we utilize at San Diego Fertility Center, and we feel that that's something that potentially can improve implantation rates in patients. There's some studies that have shown some benefit. This is currently the protocol at San Diego Fertility Center, and now there's a large Dutch study with over 900 patients that is being randomized to look at the effect of embryo glue and what we call endometrial scratch as well. So what is endometrial scratch? So in some patients, when we transfer the embryo back into the uterus, we find that there are implantation failures or miscarriages, or the embryo does not implant. In some of those patients, we use a technique called endometrial scratch, where we disrupt the endometrium, meaning that we cause a little bit of a sort of an inflammatory response inside the lining of the uterus, and what that does in the process of healing, it improves cellular growth, and we think that that sometimes can improve the uterine environment for implantation. So endometrial scratch is used, although this is not something that we typically use with surrogates, because typically surrogates have had healthy pregnancies, their uterus is typically in perfect shape. These are for patients where we find that there are recurrent miscarriages, for example, or recurrent implantation failure. Again, some studies have shown some benefit. There's a large Dutch study ongoing right now with over 900 patients, and we'll see what the results of that particular randomized controlled trial are. Here's an embryo transfer. You'll see the catheter coming from screen right to left. We do all of our transfers under ultrasound guidance to ensure the adequate placement of the embryo. So you'll see the catheter coming in, and now you're going to see a little flash where the embryo and the media around the embryo is going to be released into the uterus. Right there. And so that's sort of the area that's most conducive to implantation. So it's really important for us to do the embryo transfer under ultrasound guidance so we can maximize the rate of implantation, because different areas of the uterus are associated with different implantation rates. And so the area where we want to transfer the embryo is typically about 1 to 2 centimeters from the very top of the uterus, called the fundus. And again, we use the ultrasound to maximize the best placement of the embryo inside the uterus. This is what we do is when we do an embryo transfer on your surrogate or on you, you'll be able to see everything on the screen. You actually see the embryo being picked up in the lab on one screen, and on the other screen you actually see the embryo transfer happening. So a lot of times for many of you, if you cannot be there for your surrogate's embryo transfer, we'll Skype you in, so you'll be able to be witnessing your embryo transfer. How do we maximize egg quality? Well, maximizing egg quality starts even before we start the IVF cycle. So sometimes we use supplements such as CoQ10, testosterone growth hormone, DHEA. All of these supplements are typically used somewhere between 1 to 2 months before, and the reason for that is because eggs start their development about 6 to 8 weeks before we retrieve them. So we want to make sure we have some of these supplements on board before we retrieve the eggs to maximize egg quality. Again, we use the stimulation hormones. In many of your egg donors, if they're producing a high number of eggs, there may be at risk for something called hyperstimulation syndrome. So through a series of studies that we performed and we published between 2006 and 2010, what we discovered is if we use a different type of medication called a Lupron trigger, we can avoid and eliminate the risk of hyperstimulation syndrome. And then we looked at the egg quality with the Lupron trigger. And what we found was that the Lupron trigger egg quality was just as good as the classic HCG that we used. HCG and Lupron trigger are injections that we use right before we retrieve the eggs. They're needed to cause the final maturation of the eggs, and what we looked at in studies was egg quality that's produced from each of these triggers, and what we found that the egg quality was just as good with the Lupron trigger, but we eliminated the risk of hyperstimulation syndrome in those particular patients. And again, these were some studies that we did looking at what we call the GnRH agonist or the Lupron trigger, finding that egg quality was very consistent among all of our patients that used it. 2 minutes. Okay, so I'm going to just actually end right here because I want to make sure that I leave some time for questions. Otherwise, I just keep talking and talking, as Richard knows. Thank you.